All right, we're a little bit behind schedule here, but we're going to try and keep things moving. I'm Michael Devlin. I work with the Samara Foundation. Samara and I have been working together for the last 4 years. We've had the chance to hold events like this over the last few years, probably 15 or more of these patient days. Each one is different, but I think a key component of them is making sure that people attending, particularly the patients and caregivers, they get a wide variety of voices they can hear from, particularly on the care team. And we've already talked about the specifics of NMOSD and MOGAD. This panel is to address everything else you have to deal with as a patient living with these conditions or as a caregiver to a patient living with these conditions. So what I'd like to do is let everyone introduce themselves quickly, and then we'll move on from there. So please.
Hi, I'm Hillary Cohen. I'm a clinical social worker here at Georgetown in the outpatient neurology department.
Hi, I'm Brooke Brown, or Elizabeth Brown officially on paper. I am actually a urologist and specialize in voiding dysfunction and neurourology.
I'm Cole Hague. I'm a neuropsychologist, pediatric neuropsychologist at Children's National, part of the neuroimmunology team. Very happy to be there, and I'm still working through my embarrassment with the shout out earlier, so that's another side.
I'm Bob Shin. I'm filling in for Ben Osborne, who, as you heard, couldn't be here. Now I'm wearing the hat of neuro-ophthalmology.
Great, thanks everyone. So let's quickly start off. I know you all work with a range of patients, even with other demyelinating conditions like MS. So for MS patients, NMOSD, MOGAD patients you work with, what are the primary symptoms you see them dealing with beyond their relapses and managing their underlying condition? And we'll just go right down the line.
As a social worker, I can't speak too much to like the actual symptoms. I feel like that's better left to the medical professionals.
I'm happy to start with the bladder symptoms. So from a bladder health standpoint, a lot of times we see a large variety of symptoms from urinary urgency, frequency, and urge incontinence, all the way to urinary retention or incomplete emptying or urinary hesitancy. So very wide range between peeing too much or peeing not at all. And how to manage that. And then the bigger issue sometimes, in addition to quality of life, is also protecting your kidneys. And so we sort of look at things in two perspectives, like what is safe in preventing long-term kidney health, and then also quality of life, how to improve your urinary symptoms. And so that's a lot of what I do when I get roped in from neurology, and I'm always happy to help with any of that.
As a neuropsychologist, so you can probably guess a lot of my interest areas or focus has to do with sort of cognition and how folks are sort of growing and developing skills over time. I will say that, and it's a weird thing because I'm talking with you all about like your lived experiences, but a lot of the things that I've learned from people in the room have been and has really been sort of across from like 5 to 22, the age ranges that we see, has been a lot of, fatigue management. There can be some of the cognitive symptoms of like attention or executive functioning, which I think a lot of people hear that term, but planning, organization, impulsivity, things like that. Processing speed, things taking a little bit longer than before, motor involvement and things like that. But really it's trying to get a sense of sort of how the symptoms are affecting the person on a day-to-day basis so that I can build a picture of sort of a quote-unquote sort of like rehab-y sort of treatment plan for them. So thinking holistically about what this person needs to sort of live and function to their best of their abilities.
I just want to say I don't know that we've ever actually hung out together in person, but I used to send so many patients to Dr. Brown with bladder symptoms. It's so common with spinal cord disease to have bladder symptoms, and often people may not always be very open about sharing that. So whenever we got any sense that there were bladder symptoms, and people will sometimes just say, well, I was just living with it. But Dr. Brown,
it definitely goes both ways. So about 20% of patients actually present with urinary symptoms first, and then we do testing, and then actually get them to neurology to try to figure out what the underlying cause is. So it's mutually beneficial and helpful for people.
Yeah, it's been great. But I guess on the vision side, we already talked about how an optic nerve inflammation, optic neuritis, is one of the cardinal symptoms for many individuals, whether it's NMOSD or MOGAD, or even MS for that matter. And visual symptoms is pretty broad. It could be vision loss, which we heard about a lot today. But it can also be things like double vision or even shaking vision. So these are all things that we work on in the neurophtho clinic.
and I want to come back to Hillary. So we've funded research on the impact of NMOSD on the income of patients, and we learned through Fermatine, who was at Harvard, I think she's now moving to Northwestern. Nonetheless, she found that NMO patients can lose over half their income because of their inability to work, which then spills over into loss of insurance or maybe ending up on Medicaid, having no ability to pay to get to and from appointments and infusions and whatnot. And it also impacts their caregivers. So could you tell us a little bit how you work with these patients as a social worker?
Sure. Yeah, unfortunately, that is not an uncommon experience with neurology patients. And it's tough because there are resources in this in the DC area. There are resources. In other areas, I know, like in more rural areas, kind of as we talked about with the other discussion, like there's just not as many resources there. So, I can kind of help set someone up like with transportation, or I can help like with food assistance and different things like that. But I think it's really devastating for patients, and so I think like they're having to catch up with what's going on in their lives. They're having to manage physically what's going on with them, and they're having to deal with like this absolute devastation of this massive loss, and it's real grief, I think, and it is real grief. So there's a lot of layers, I think, that the patients have to deal with, and I think when I work with them, it's a lot of meeting them where they're at. What's their experience been medically? Can I help them relay any messages to doctors? Can I help sort of bridge any gaps on their behalf? Like, what resources do they need? I often send resources to them to apply for different grants and things like that. I have my contacts where I'm like, oh, call this person to help you apply for disability, call this person for this. And so that's really helpful to kind of have that. I think that doesn't exist everywhere, which is very difficult. But yeah, and then I always sort of bring up with patients, have they considered therapy, talking with someone, and seeing if that's something they're interested in, and even do some short-term counseling myself with patients.
Yeah, that's so important. And I think actually just for everyone, you should always reach out to a social worker. They know all the resources available in your local community for copay assistance, transportation assistance, getting to an infusion clinic. If you live alone and you don't have a strong care team in your family or amongst your friends, they're often the folks that can really help solve that key problem of not, being able to get to your infusion, which if you don't do that, you're going to be having a lot of other challenges as a result. So it's super important what you do, and we really appreciate it. Just broaden it a bit. What we have heard from many patients, once they're diagnosed, they see the neurologist and they get their treatment, and they're feeling they've addressed their relapses, but they stop there. They don't actually realize that there's a whole broader care team that could be involved to help them with mental health or their vision, or in the case of physical therapy, with their mobility, or with other challenges, a social worker. How do you all talk about your newly diagnosed patients, about the broader care team? How do you get them to mental health or to incontinence support, et cetera? How do you talk about that with patients?
Well, I might weigh in. We didn't work together when I was at Georgetown, so we didn't really overlap. We had a different social work at that time, but it does take a village. And I would say, Michael, to your point, at least when I think about our visits, and some of you are in this because let's say when it's new, when someone's been newly diagnosed or someone just got out of the hospital, you're initially just dealing with that attack and recovery of that attack, grappling with the new diagnosis you've received, having conversations about, well, there are these multiple treatment, that sort of thing. But I feel as though it usually takes, I would say, maybe 3 to 6 months to get through that recovery process, have those conversations, hopefully get you on a highly effective therapy. And when the dust settles, the goal should be for things to get super boring in that regard, okay? Then I do think it is important to look at a second layer, which would be, but what about the existing symptoms, whatever they might be from that episode? Is there residual vision loss? Are you having neurological bladder symptoms? Have you been struggling with some degree of mood disorder or changes in terms of cognition and energy level? Are you experiencing pain? So symptom management is an extremely important pillar. And then a third area that I think has been touched on in a different panel is wellness. That's always quite, discussing things in terms of making sure that you're attending to emotional health, making sure that you have a good diet, making sure that you're making good lifestyle choices, right? But I feel like if you keep all three pillars in mind, once pillar number one has been settled out, is when I think you start to engage the other team members who are going to be involved to help with that symptom management.
One of the ways that we do it, which is going to come off like a plug for Children's National, which in some ways it is that we actually have a multidisciplinary team where we go in, and so I'm in most clinics, I would say, but I think a lot of this we have to give up to Dr. Cohen and the other stakeholders, because she sort of built this and was like, we need this kind of specialty level of care for the patients that are coming through, because it's not just sort of like a diagnosis, med management, see you when there's problems again kind of thing. I was told back when I started learning about neuroimmunological conditions like a decade ago, so I'm more new to this than I think other people, but is that they're longitudinal, they're long-term conditions, right? So we're not just treating the individual in sort of this acute phase. We have to think about what's going to help them sort of navigate the rest of their life well. So we try to bring people in. So as the neuropsychologist, I will sometimes go in, usually with the neurologist, as we sort of get a relatively good history. But we also have a lot of students that come with us. We have a social worker that does therapy on our team, is also involved in some research and mindfulness-based interventions. We have an awesome research coordinator. We have like the best nurse that I think that the nurse coordinator that I've ever seen. And so it is sort of, it's a small team, but it is sort of a powerful team. And you can kind of see that makes the big difference, even in just the way that we talk about patients, because we go into the rooms together, we come back, we debrief with one another, and we talk about what's this kid going to need for the next 3-6 months, how do we route them, how do we get them the services, and people are already making moves by the end of that visit. And so some of that just has been built by people who built it before I got there. So, yeah.
Brooke, any thoughts on how patients connect to you?
Usually by referrals from wonderful neurologists to put them in our clinic. Unfortunately, we don't really have the resources for a multidisciplinary clinic, although we've talked about it some. But for us, keeping people engaged, so again, kind of going back to kidney protection, I have all the patients with any neurologic condition check in once a year with an ultrasound of the kidneys and kidney function monitoring, and then at least they sort of have a standard check-in, which is nice to keep people engaged and make sure that they're not having worsening of symptoms and then not following up. So unfortunately, a lot of the bladder medicines, for instance, have some side effects, and sometimes people will stop them and not really understand that there are other things, more procedure-based treatment that we can do, although I know I say that at the beginning, but it's almost like such a flood of information and knowledge. I think sometimes that's forgotten, so it's nice to sort of have that annual check-in point, if not sooner, and certainly if people are struggling, we have people come back more frequently.
And then Hillary, how do patients connect to social support?
I mostly get referrals from the doctors. I have gotten a couple self-referrals from patients, but the majority is from the physicians who reach out and say they met with a patient and they have this need, and so they connected me, and then I'll reach out.
It's interesting, though, many of you make this point about the importance of a multidisciplinary care team, and I think there's a movement now, at least at the larger medical centers, to try and create this sort of team for patients living with serious conditions, rare diseases, but it's the exception more than the rule, I would say. Sometimes it's just resource limitations, and I think this is where we have to shift the focus a bit to patient self-advocacy or caregivers advocating for their patients to make sure that if you don't have access to these specialists, this broader care support team, you need to find a way to get to someone outside of perhaps your usual site of care to connect to people that can help you with these other issues. And we actually did a panel that included a urologist a few patient days ago, and they were very thoughtful, and it was, I think, the most viewed session we had after the fact, including by many patients from other diseases, because A, it's hard to talk about, B, you don't easily find information about it. So I'd love to hear a little bit more about the progress in incontinence, all the various technologies, et cetera, that are available to help patients with this issue, because it is quite common in NMOSD and MOGAD, and yet most patients are a little bit hesitant to ask questions about it.
One thing I would say about patient access that I think people don't know, and at least for us, we can do telehealth very easily. So don't feel like you necessarily need to come all the way into Georgetown, DC and deal with this parking garage. There are plenty of ways that we can touch base virtually. Most of us have licenses in DC, Maryland, and Virginia, so I have plenty of patients that live down in rural Virginia, and we check in over the phone. So just please know that. Sometimes it's hard to get that initial appointment through central scheduling, which we all know here, but just know that it is possible, and if you push, we can certainly make it happen. As far as bladder health in general, it really depends on the issue, whether you're not able to urinate at all or if you're going too much or having incontinence. But there are a lot of procedure-based treatments which require some intermittent non-telehealth appointments, such as putting Botox in the bladder. I would say often that's the most common thing for urgency, frequency, and leakage associated with neurologic conditions, but it's a very quick office procedure. It literally takes me a minute and a half. Patients love it. It works very, very well. There's also almost like a pacemaker for the bladder, which is more of a surgical procedure, but lasts on average for about 10 years. And then there's an acupuncture type treatment, which does require more frequent visits. But if you're seeing benefit from that, we can actually teach you how to do it at home with a TENS unit, which is super helpful. So even if you're coming from far away, if we can kind of get you on the right track, then that's something that you can do in the comfort of your own home. So that's more for the urgency. As far as the other side, not emptying as well, some of it is different between men and women based on the prostate, and so we can do some testing here in the office to see how much that's playing into it. There certainly are different options for catheterization and things. Our nurses are excellent at teaching people how to use catheters and helping urine get out if it's not coming out the way it's supposed to. And there is a lot of research out there, but unfortunately right now there's like no magic pill to make the bladder squeeze better. I think that's one thing that we really struggle with in urology, and we are trying to continue research for that. But I'm certainly happy to answer any further questions. We usually do recommend for anyone that has neurologic conditions and urinary symptoms to see a urologist, have baseline testing, which is a test called urodynamics, where we have you urinate in the office and measure some pressures and also take pictures of the kidneys just to make sure that everything is safe and that there's no long-term damage to the kidneys happening.
So follow-up question, you're the best place perhaps on the panel to answer this. Could you talk a little bit about the common sexual dysfunction that many patients with NMOSD and MOGAD see, and where can they go to for help?
Sure. So any of my partners do a lot of the sexual dysfunction. So there are medications available, which is probably what most people would begin with, Cialis, Levitra, Viagra. The one thing I have told a lot of patients recently about Cialis is it's actually also approved for enlarged prostate and urinary symptoms. So I really like that in some of these situations because you really get a benefit to help the prostate open up, make it easier to urinate, and help for erectile function. If the medicines aren't enough, there is actually medication that you can inject directly into the penis, which works very well. It sounds traumatizing. I just heard and saw a lot of people's faces. But we teach everybody how to do that very safely in our clinic. And it's actually very successful. And we first started doing that for post-prostatectomy issues, so men that have had their prostate out for prostate cancer. So this has been out for many, 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 many years. It's very safe and effective. And if that's not enough or not helpful, then there is a surgical implant called a penile prosthesis, which you can also do to physically pump it up when you need it.
So just a broader question, are there any sexual dysfunction issues that women face, and if so, how do you address those?
Female sexual dysfunction is a little bit trickier because of some of the hormone changes too. So a lot of times we'll start off with vaginal hormone replacement and sometimes a combination of vaginal estrogen and testosterone compounded creams. There are some medications that are out there, but they do have a lot of side effects. And we do have some colleagues that specialize in female sexual dysfunction that have a university appointment that we could get people to as well.
Very helpful, thank you.
Sure.
If we move on to the topic of mental health, Cole, NMOSD MOGAD patients faced a constellation of issues from brain fog, as they call it, or even mental stamina / fatigue, or just depression. So what's the constellation of symptoms you address, and are there other specialists you sometimes pull in to help with other mental health issues?
Yeah, of course. So as a neuropsychologist, my role is really like assessment, diagnostic consultation is sort of the way that I frame it. But like I said, there's sort of like the treatment planning roadmap that you develop after you sort of get a good idea of how a person's brain is working well, and in other ways that you want to leverage strengths against areas of challenge, which we all have. I would say that a lot of the signs and symptoms that people experience, including fatigue and including like maybe their disability is not as visible. I think there can be a lot of invalidation associated with that. I think if you're having challenges with so processing speed and things taking a little bit longer is a really common symptom. And one of the really hard things is that the damn world doesn't slow down for you. And I really wish it would. But I've tried to, and I know we've talked about this a lot this afternoon, but I've tried to be mindful of that as a provider and give people sort of time and not interject a whole lot. I think that's a big point that we can do, but I think in that same vein, you want to find sort of a coalition of providers who understand you and see you and can appreciate sort of the levels of need that you have. I have a lot of folks that are in their early to mid 20s that come to their appointments with people and that are also sort of taking good diaries. I think that was an excellent suggestion. And organizing themselves both through like notes and apps and things on their devices, which I also think is a really good strategy. I think the number one thing that I would probably recommend is therapy. And that probably sounds like a cop-out as the mental health guy on here, or one of the mental health people on here, though I know that we're all invested in that. But I find it's also a point that people feel a lot of apprehension about. Are they gonna get me? Do they understand this disease? Do they understand what I have to go through? The answer is no, they're not, right? But a good provider is somebody who's going to actually listen. More than 50% of the reason, not to be a huge stats nerd up here, but more than 50% of the reason that therapy works is because you have an alliance between you and your provider. That they get you and you get them, and you feel like you can tell them things, and they're going to be able to hear it and acknowledge it, and they're also going to be able to say when they got it wrong. I think that the speed dating idea from Unica, right, was amazing. Great framing there. I think that's a really, really smart thing. And I think especially in the mental health field, you have a variety of different sort of credentials and things, some of which correspond to actual value and some of which don't. But again, I think if you can vet these people and see them a few times and work with them and say, okay, well, what do you think about this and what do you think about that, and this is what I'm going through, and do you see that and do you hear that, and can you sort of understand me through that lens? That's probably somebody that you can stick with. So
that's helpful. We like to think of our patient days as speed dating with all the doctors in the area near you. So great point. Bob, when it comes to vision loss or vision impairment after an acute relapse, what are the types of things patients can do to help with their vision or accommodate the impairment?
It very much depends, I think, on what the visual issue is. So, for example, many stories actually, their story began with subacute loss of vision, blurriness, constricted visual fields, flashes of light. The prognosis for optic neuritis actually is often quite good. So if you think about, we work backwards with MOGAD, actually one of the hallmarks of MOGAD is there's a lot of inflammation of the optic nerve, and you heard earlier at the very beginning, there's swelling of the nerve, and the MRI shows a lot of inflammation, and sometimes the visual loss is severe, but often they have actually very good visual recovery, especially initially with treatment. NMO spectrum disorder, and you saw it, you said, oh, I went to the internet, they said I was going to die in 5 years, or whatever people were told, but also still actually in slide decks and conversations, NMO spectrum disorder leads to permanent blindness and disability, which I'm going to say, at least in my recent experience, isn't necessarily true. with early identification and treatments like corticosteroids and plasma exchange and early use of highly effective therapies like the ones we heard about, in my experience, patients with NMOSD also can have excellent visual recovery. That doesn't mean that if you compared the two eyes, my patients often will be able to tell which eye had the optic neuritis. But I would say that with early identification and effective treatment, most patients are not significantly visually disabled from their optic neuritis. So some of it is actually reassurance. And in fact, a lot of my patients with these conditions who come to see me for vision issues, I discover the visual issue isn't actually the optic nerve issue, because just having this diagnosis doesn't prevent you from having regular stuff that everybody else has. So a lot of it is about identifying the root of the vision issue, and very often, actually, it's quite treatable. I don't know how much, detail you'd want to go into with vision. I was going to make a comment on everybody else's statement. You all had actually much more important things to say than I did, but maybe to someone like Nell, earlier when people were talking about that transition from an amazing clinic like at Children's National, where Ilana Khan, Dr. Khan must have set up this multidisciplinary clinic where you can have, in one day, you can see 5, 6 people can kind of rotate in and out of the room. That would be very unusual in an adult setting. And I would argue probably isn't actually practical. But that doesn't mean that you won't have the team approach that was described here. So I would say that just like you described at MedStar or at Georgetown, at UVA, we try to have the same thing. So everybody you mentioned is so critically important. The nurse navigator to help with our patients, the PharmD to help with conversation about treatment options, PT, OT, speech-language pathology, having a consultant who's knowledgeable about bladder symptoms, having neuropsychologists, which we have integrated into our clinic as well, and making sure that we address the mood disorder that commonly accompanies these things is important. It may not be done in that same model of in one day you see everyone coming to see you, but I think, as Michael pointed out, that is the trend. The recognition that that's what it takes to really effectively help people living with these conditions.
And I know that many patients live with mobility challenges or impaired mobility. We don't have a physiotherapist or a mobility specialist here. Normally we would, but somehow we didn't line one up. But could you all just talk broadly, to the extent you can, on how patients might get help with mobility issues after a relapse?
Well, I was actually going to bring back up another treatment option, which I didn't say initially, but pelvic floor physical therapy for us is a huge thing. And if any of you are my patients, it's the first thing I usually tell people besides avoiding bubbly water and other bladder irritants. But pelvic floor physical therapy is great in addition to all other physical therapy, but specific for bladder health. There's a huge combination between your bladder symptoms and what's going on in your back or your hip or your knee or your ankle. And so if there are mobility issues, a lot of times it does present as incontinence, and then people are very confused as to why they're having a urinary issue when they hurt their ankle, but this same thing is true with any neurologic condition. So definitely having a physical therapist that can treat all of the symptoms can be helpful. Getting access when there's mobility issues is certainly the biggest issue, like getting to that person in the first place, obviously. But from my standpoint, specifically going to a fellowship-trained pelvic health physical therapist is super, super helpful. So that wasn't exactly the answer to your question, but mobility definitely affects what we do on a day-to-day basis.
Well, but along those same lines, physical therapy for ambulation is so important. I think we used to talk about these conditions as, especially when we didn't have treatments. It was as if there will be this inexorable worsening. Like there's almost no hope. Like, well, maybe I could slow it down so you get worse more slowly, or there's this very sort of nihilistic attitude, and it's really not true. A lot of patients, actually people who have spoken today, may have had the experience of at one point being unable to walk and then learning to walk again, regaining a tremendous amount of function. And it's really not a drug that does that. It's the hard work of physical therapists and occupational therapists who work with, and obviously the hard work of the patient themselves. But it still surprises me when people come to clinic and perhaps are using an assisted device. And if you ask, and are you getting physical therapy? And they've never been offered physical therapy, to the point of maybe the doctors focus so much on the diagnosis and maybe a drug, but never got to that point of, but we also should help with the existing disabilities. So it's very gratifying when you can engage someone or connect them with that and see the improvements they can make.
Yeah, you raise a very good point, because I'm always stunned whenever we have a panel of patients up here, when they tell you how, at their worst point, how, you know, they were completely incapacitated, unable to see, walk, do anything. And we have patients now that are running marathons. Marianne Jones is on her, what, 4th marathon now? But it's amazing how much recovery can happen even if you had a very severe relapse. I think it's very encouraging.
I don't do a lot on the intervention side, but what I try to do from an educational perspective is just say a lot of this is like an energy conservation cost-benefit analysis. But I also really encourage people to still try to live the lives they want to live, and so be active and physically fit. And I notice that people, when they're not deconditioned, they feel a whole lot better, but there's also like accommodations both at the collegiate level, like priority course registration. It helps you to sort of adjust the day so that way it can flow a little bit better. You can build in some rest periods. You can make sure you get enough sleep the night before. There's also sleep recs that I walk people through, because oftentimes sleep can be disrupted. There's sort of the heat there's a lot of excess heat that people have to manage, so it can be layered. But there are sort of workplace educational accommodations too that you can leverage. So.
And Hillary, I'm wondering, workplace accommodations, is that something that social worker can sometimes help patients with?
Yeah. I actually don't think I've gotten. I have gotten that question before, and patients can reach out, and I can help them find, like, there are different forms. There might be a letter needed from the doctor, different things like that that I can assist the patient with, because I know it's a lot to do for a patient, and so probably just needing some support is helpful.
I've written a lot of letters for bathroom access, for sure. Like to have a bathroom near your office, or like for even teachers. One of them was out in a portable, and I was like trying to get her into like the main building where the bathroom was. So there's definitely a lot that we can do, but we don't know what the individual work situations are unless you share that. So definitely that's an important part of what we do as well.
That's great, and I know we're over time now, so I'm going to try and wrap it up. Just any last thoughts on other aspects of a health and wellness program? So diet, exercise, other things you really encourage your patients to do. I know everyone knows in practice that's a good thing to do, but what are your opinions on this? What do you tell your patients when you see them about other aspects of health and wellness as patients living with rare disease?
The first thing that comes out of my mouth if you're having urgency, frequency, or urge incontinence is to avoid coffee, tea, soda, alcohol, spicy foods, chocolate, artificial sweeteners, sports drinks, and bubbly water. All the vices. But if you don't want to do that, we can put Botox in your bladder and you can still have your coffee. Go. Sorry.
From a mental health point of view, sorry, I lost my train of thought. Sorry, someone else go first.
Sure.
Jump in. Anyone can jump in.
I'll be honest, I don't, and this came up earlier, I don't endorse like a special diet. People always ask me, I read, maybe I should be on this diet, or I should take this supplement, or I should do this special thing. And to your point, usually I think it's simpler than that, right? Having a healthful, balanced diet is really good for all of us. Making sure that you minimize stress as much as you can in the real world, and try to pay attention to yourself, make yourself some focus and get yourself enough rest and recovery, attending to your emotional health as well, and staying socially engaged. These are things that are actually good for all of us. Like, there's not anyone in this room who would not benefit from that. But it is important for someone living with a chronic illness to make sure to put a little bit of emphasis there, for sure.
Okay, I remembered. Sorry. Sorry. So I think from a mental health point of view, like, if you're given a diagnosis that feels really overwhelming, feels really scary, you're going to want to adjust your life in some way so that you don't feel quite so overwhelmed. So I think like this whole notion of like self-care, people are often like, take a bath, do meditation. Those are great, but honestly, I think what self-care really is being able to know your boundaries. Like, if there are things you can take off your plate in your life, do it. That if there are things that are causing you a lot of stress that are not necessary, I think it's important to know your limits, to know your boundaries, and be able to, prioritize what you want to keep in your life, what you feel like you can maybe walk away from, even temporarily, because this is such a big thing to wrap your head around, and you want to make sure you're taking time to rest physically, mentally, and yeah. So.
Just one last thing is, so again, more in the peds realm, but I see how this really affects whole families a lot, because usually the patients come in with many members of their family, which I understand and really appreciate. But I also think that this has been traumatic for a lot of the caregivers in the room and even some of the other kids. And so I think that even family therapy can be good, or everybody having their own sort of social emotional support system is good too. And everybody should try to talk about it as much as you can in sort of a healthy, normalizing way. I find that more of the keeping it in tends to sort of, my line is you can tame it if you can name it. So I think talking about it out loud does help to give us the tools to be able to work through it. So it's important for families and individuals.
All great points. And while we have this distinguished panel up here, I just want to quickly ask anyone, any questions from the audience for, oh, we've got one over here, and another one in the back, and a third one.
I'm a translational neuroscientist, so I have slightly a different perspective, and maybe I'd love to know whether you have seen this in your patients, or if anybody has seen it in themselves. But there's a lot of cells in the retina that project to different parts of the brain that don't form roles or functions in image formation. But they control everything from our cognition to our emotions and motivation. And I'm wondering if this might be something to just pay attention to. People wear a lot of wearables, right? So we can gain insights into circadian function, light controls, temperature. There might be a lot of behaviors or a lot of subtleties that might be a good kind of canary in the coal mine for a potential relapse that might be coming, or something that starts to integrate dysfunction in sleep, mood, motivation, and may or may not give you something to think about for treatment. But I would just implore you all to think about this, or if you know about all this already, I'd love to hear about it.
Sure, that's a great topic. We could talk all day, but to your point, as you said, our eyes are not just for vision. Light information that enters the eye travels to other parts of the brain, some of it to work things like our pupils and things, but a lot of fibers travel to the hypothalamus and regulate things like circadian rhythm would be a more obvious thing, but maybe mood as well. You talk about seasonal affective disorder and people who use light therapy to help with that. So to your point, could we learn to detect maybe an increase in irritability or a disruption in sleep patterns that might herald an increase in inflammation? It hasn't been done yet, but I think it's a really cool idea.
Yeah, we're happy to have you write a research grant for us, and we can apply jointly to do. Great ideas. We have a question back here.
My question has to do with sleep. Do you have any recommendation for sleeping, getting those hours of sleep? I exercise, I watch, I monitor my diet, I check the junk.
Yeah,
but I can't.
I wish we had so much more time to talk about these things. And I didn't mention it specifically, but there is actually a lot of literature on sleep disorders associated with these conditions, which maybe shouldn't be so surprising because the brainstem helps us control sleep. We just heard a little bit about circadian rhythm. Fatigue management came up a little bit, but there are specialists in sleep, focus on sleep disorders and their, if you will, coexistence with all the conditions we talked about, whether it's MS or NMOSD or MOGAD. And there are, I mean, not to overdo it with specialists, but there are literal sleep medicine specialists who could help do an assessment. Because again, it may not just be, man, I'm doing everything right. I'm staying off my iPhone. I'm trying to be regular. I'm avoiding caffeinated beverage and bubbly beverages, I guess. But sometimes that's not enough.
That's only if you're waking up to go to the bathroom at night. That's the only time I can wait.
But, it's so worth exploring the fact that if you're experiencing something like that, that is a symptom that we should try to get an answer for you for.
Yeah, and we also didn't talk about pain, but we find from talking to patients, many patients have trouble sleeping because of neurasthenic pain. And since Dr. Banwell's not here, I can say this, but there's some work we're supporting with research grants on the role of marijuana to help deal with sleep and pain at night. And it's we've had a few focus groups with patients. It's astounding how many patients have tried everything else, marijuana or THC is the last resort, and it's worked very well for them. So they're now doing a study at Harvard, led by Anastasia Wisniewski, on exactly this question. Hopefully we'll get an answer soon. And we have one more question.
I have a quick question. Thanks so much for, again, I'm always extending gratitude. But we had a quick conversation earlier about sexual dysfunction and sexual health. But this might not be so much a conversation at the pediatric level, doctor, but for adult patients, how do you have discussions regarding fertility? In a lot of my discussions with patients, fertility is a common topic because we know obviously that MOGAD is 50-50, but NMOSD is more female patients. How do you approach discussions of fertility within your practice, if at all?
So I can only speak on the male side since I'm a urologist, not OBGYN. But as far as for male fertility, I actually usually refer them to fertility specialists. So we do have andrologists in town that can help with any ejaculatory dysfunction, sperm retrieval. There are lots of techniques. If it can't come out, you can go in and get it out. And there are lots of people in town that help at the different fertility centers specifically. On the female side, similarly, there's reproductive endocrinologists that can help kind of in the same vein.
And this is another hugely important topic that in our space we've become increasingly aware of the importance of bringing it up or opening the space to bring it up as early as possible. And this is what we discovered for a while. We got so focused on making the diagnosis, and then we got so focused on you need to be on a treatment, and it's going to be injections or infusions or something. And we discovered that we wouldn't even, eventually things would get stable, but then we'd have a conversation. It would be a little bit later when it is harder to get pregnant. And I think there's been a move in our field to, even from the first conversation, at least broach the subject of what are your plans. And so a question we've incorporated in clinic, every clinic visit, sort of as a standard intake, is, are you considering having a child within, and that it doesn't matter who the individual is, their gender orientation, whether they're male or female, just are you or your partner considering this? And it does open up space for that conversation because one is, just to be clear, none of these conditions in any significant way affects fertility. And we're also fortunate that many of our treatments, though highly effective, also, when used carefully, are completely compatible with having a child early on. And so I'm glad you brought that up because we had to learn to bring that up as early as possible to basically maximize chances if someone wants to have a child.
Very helpful. If I don't end this panel, Samira's going to shoot me, so we're going to stop here. Thank you very much for your participation.